Hello friends, here I am presenting a case of MICS in a patient with floppy iris managed using Made in India Gupta Ring Pupil Expander. The patient is a 70-year-old male who has been using tamsulosin for last 15 years for his BPH. The pupil was not fully dilating, and after staining the anterior capsule, I decided it prudent to use an expander as the iris may become floppy at any time during the surgery, thus making things complicated. At first, I injected 1% lignocaine into the AC to anesthetize the iris, as placing the expander might cause patients some discomfort otherwise, as this case was being done in topical anesthesia. Now, the AC was filled with 1.8% sodium hyaluronate. This retains in the AC and keeps it deep, thus reducing chances of endothelial touch during expander manipulation. The main wound was created using 2.2 mm keratome. The pupil expander was loaded onto a 2.2 mm cartridge. It's the same one which we use for IOLs and injected into the anterior chamber. The Gupta Ring Pupil Expander is a four-flange system, which holds the pupil at 4 points and thus keeps it expanded and making a square-shaped pupil. The four flanges are tugged at the pupillary margin using a Sinskey hook. One doesn't need to change hands, as the expander slides easily over the pupil, and thus all the 4 points can be done using the same hand. Now, the AC was filled with HPMC and Rexis was initiated using a cystitome. Good pupil exposure was achieved and a Rexis of 6 mm was easily made. Now, rectal hydrodissection was done. The AC was filled with HPMC to protect the endothelium, and Phaco emulsification was performed. And the nucleus was emulsified and aspirated. One should note that during this whole procedure, the iris did not move at all, thus making things easy. Now the remaining cortex was aspirated using bimanual IA. The capsular bag and AC was filled with HPMC. A single-piece monofocal hydrophobic IOL was injected into the capsular bag using 2.2 mm incision and its haptics dialed into the bag. The expander was now disengaged using Sinskey hook and was pulled out from the AC using McPherson's faucets. Viscoelastic removal was done using bimanual IA. Note the frequent movement and catching of iris onto the aspiration groove. This would have happened during Phaco as well if the expander was not in place, thus making things easier for us. Air was injected into the AC and intracameral pilocarpine was injected to constrict the pupil. Stromal hydration was done to seal the wounds and the case was completed.